it's 3 o'clock. I'll go ahead and kick off and get us started. For those that are joining us on Facebook Live, we appreciate you coming out. And for those joining us on Zoom, I always love it when we have a good audience on Zoom because this is where the interaction takes place. It's not as easy for me to manage Facebook comments, but I do encourage people to put those in the live feed and we'll respond to them. Even if it's after the meeting, we'll try to get you some answers. So if you have any questions for us or anything like that, feel free to type them in Facebook, or you can chat with me on Zoom if you'd like using the chat feature. But I'm going to go ahead and ask everybody who's not speaking to mute the volume on their Zoom call so that it's really nice and quiet when Dr. McLeod gets to speaking here in a little bit. And if you're just now joining us, that's great. Just go ahead and stay on mute. And I do need to let everybody know that we're live streaming over to Facebook. So if you don't have a desire to be seen over on Facebook, you're certainly welcome to turn off the video feature on Zoom. Depending on what kind of device you're using, what I say may or may not make sense. So if you're on a computer, a regular desktop, down on the bottom left, if you move your mouse down there, you should see an option that will say stop video, and you can click on that and turn off your video, and that way you don't have to worry about being a Facebook star. It will show up on our CSRA Parkinson's support group page, but that's the only place in there, of course, unless somebody shares that on their own page. So real quickly, I wanted to let our group, for the benefit of our general members, know that we had some changes in our board positions. We just had our strategic planning meeting for the year. So we have a couple of people who are rolling off of the board or leaving, and that one of them is myself. And then Joe Kelly, who was head of our research committee, and Kay Hayes, who was our head of the fundraising committee. Those folks have also rolled off the board. But we have some new folks coming in to take on some great responsibilities. So Logan Bakes, who's been on our board for a while, has stepped up into the role of president and also publicity and also the walk chair for this year. So he will have his hands full as we head into 2021. Dick Reynolds, who's on our call here today, has stepped in as the secretary and also as the head of our research committee. So if you are involved with our research grants or seeking one of our research grants, Dick Reynolds is now the key contact person for that. And then other board members who are remaining and still doing their previous roles, Lisa Sistar Harkins is our vice president. Penny Triplett is our general treasurer. Marianne Navarro is our walk treasurer and also head of our respite committee. And then Nathan Cyril is our newsletter editor and IT guy. And other board members include Pam Elrod, Connie Nestoruk, Kathleen Reynolds, and Stefan Swafford. Also, Martha Ann Tudor, who was previously on our board, has stepped more into a role of liaison. So we're glad to still maintain that connection and that support from Augusta University's Movement and Memory Disorder program. All right, so I think that's it for my general announcements, and I will kick it off and turn it over to Dr. Colin McLeod. He's a neurologist and movement and memory disorder specialist at Augusta University's Movement and Disorder program. And he'll be speaking with us today on medications for motor symptoms with Parkinson's disease. So Dr. McLeod?
I'm up. I guess that means that's me.
That's you.
Let's see. I think I need you to undisable screen share. I think. Almost.
You should have control now.
You got it. Right, you are. Okay. Can anyone see my large, obnoxious cursor?
We can see your cursor and the presentation.
Excellent. I love that it's large and I can point to things here. So hi, I'm Dr. Colin McLeod. I'm an assistant professor at Augusta University. That is accurate. I'm a movement disorder specialist here at this Parkinson's Center of Excellence. And I'm speaking to the local group here. So hopefully I know some of you by now. I've been here a little over a year. And we'll talk about motor treatment for Parkinson's disease. So the outline, give me half a second. I'm going to pin this so I can see the whole thing.
And while you're doing that, Dr. McLeod,
Yes,
just so you know, you mentioned a large mouse. It's not translating to us as large, so I didn't know if you were being sarcastic or if you really.
I'm sorry. I tried to make it large. On my screen, I made it large and orange, so it's small and white.
It's small and maybe orange, but we can see it, so you should be good. I just wanted you to know it's not as big as what I think you might have hoped.
Oh, okay. Oof, do I dare try and rectify that?
You can. I didn't want to interrupt you later on, but
No,
I just wanted you to know.
I love it. No, this is great. Let's see if it can make it large and very obnoxious. Let's see. Ooh, makes it hard to click. How about now? Same?
It's still the same size.
Oh, maybe they don't let me change the size then. Okay, well, good to know. So for the outline of this talk, I think it's pertinent if we, let's see, that we do kind of a brief overview of Parkinson's disease physiology, including non-motor contributions. I know this is mostly a motor talk, but we'll get there. And we'll kind of define the motor symptoms of Parkinson's disease, which really will help guide what the goal of any of these medication treatments would be. And then we're going to go through medical therapies kind of specifically with the whole patient in mind and why we might do what. And then I want to reiterate, of course, I don't need to tell this group, but Parkinson's disease symptoms and complications of medications and disease courses are extraordinarily different in each patient. So I do not recommend generalizing to each patient because disease courses and the metabolism of these medications and everything is just so unique. So this is a slide that I tend to start with, and it shows just the basics of kind of alpha-synuclein buildup and based pathology for Parkinson's disease. We've known for a long time that the deeper structure in the substantia nigra, which holds a lot of dopamine stores, is lost in Parkinson's, that the cells die deeper in the brainstem. And these are the stores for dopamine that project into the brain. I'll go over this in a minute, but this was so easy to see for so long, over 200 years plus, because of the loss of pigmentation in these cells. So that made it very easy to see for a long, long time. I'm going to circle back to this figure over here eventually. Don't need to understand the details of it. But the idea was that these cells here, the dopamine cells, were easy to see. And when we gave people back dopamine in the 70s, that eventually ended up winning the Nobel Prize, it was so easy to see the benefits. But it's actually also the non-motor symptoms that we're now understanding a whole lot more in some of these other stores that we'll talk about at the very end of this talk as well. I'll circle back for that. So that loss of dopamine and its projections into the brain ended up being that we found out that the circuitry in the brain is complicated. This is actually an extraordinary simplified form of it, but that the circuits that allow us to move are pretty complicated, and that several areas just with turning off the upstream dopamine either get overactivated or underactivated downstream. And we could see that just in these electrical firing patterns deep in the brain structures that we know to be either abnormally active or abnormally inactive in Parkinson's disease when missing this gasoline. So missing the dopamine gasoline that comes from the brain stem projecting into the deeper brain, we see these abnormal cell structure firing patterns within this circuit. And this was on the way to discovery of something like deep brain stimulation. And again, this actually also won the International Best Prize in Medicine, the Lasker Award for this discovery. So the motor symptoms in Parkinson's stem from that lack of gasoline and to oversimplify. And the terms that patients will tell me is being having shaking or slowness or stiffness, cramping, dancing, drawing postures, and then worsening of their overall standing, sitting posture, shuffling, speech, swallowing, balance, breathing. These are words that Parkinson's patients tell us. The cardinal symptom that must be had by definition is called bradykinesia, or a special kind of slowness. So really, it's a special activity that I'm sure all of your Parkinson's doctors have had you do, whereby you have to do repetitive tapping techniques or grips or movements. And not having that gasoline makes it such that your strength is intact, but your ability to sustain and coordinate movements is what's lost. And that's very special to this problem, and why it's this special kind of slowness or hesitation or inability to sustain these movements that hinges on the diagnosis of Parkinson's disease, not, for example, tremor. Tremor does not make for Parkinson's. If somebody has tremor, but they do not have this bradykinesia, they do not meet criteria for Parkinson's disease. So it's that special kind of slowness that's the main feature of Parkinson's. Some people have tremor. I'm not going to go through all of these, the detail of these slides, but this is just for context of medical treatment. We could have a whole separate movement Parkinson's phenomenology, as we call it, lecture. But as you know, the tremor is usually at rest. Not all patients have tremor at all. And tremor from Parkinson's is not the most common tremor on earth. So some patients are allowed to have more than one type of tremor. Rigidity and stiffness is another issue that we look at. We test it at the bedside, and it might reduce your arm swing, or might reduce the range of motion, might worsen posture. Dystonia is another kind of more specialized condition that not everybody gets, but it's an abnormal contraction of either toes or posturing of the foot, cupping of hands. Some people rarely can have blepharospasm or closure of the eyelids in relation to this, dystonia in the neck and back. So this is again, and we'll kind of keep track of these things. It's important to note, if you have these symptoms intermittently, when you have them in the course of your day and in relation to medications. We'll circle back to that. Very similarly, dyskinesia is kind of a special term. It's a bit of a lazy term as far as we're concerned, but it's a term that was popularized to more specifically mean wiggling movements that are especially associated with medication use in Parkinson's disease. So patients may say that they have writhing or swaying or wiggling or dancing different from their tremor. And it's so important to be able to distinguish that by history. And that's part of what we try and do because as you'll see later, they're treated so differently. So this term is often used to describe a wiggling movement, typically with higher dosing of medications when those medicines are at their peak. Wiggling can start just at the start or right at the end of a particular dopamine dose, but most commonly, wiggling will be when a patient is at their peak of their dose and they're typically feeling kind of their best, but they have a side effect of this wiggling. Patients may not notice much of the wiggling as a side effect of the medication, and it might not be troublesome to them at all. And if it's not troublesome or functionally limiting, then we need to have a conversation as to whether we need to do anything about it. So here's an example. I don't know if it'll play, but so this is Michael J. Fox at a younger age, and especially watch, of course, hidden by this graphic, his dyskinesias are most prominent in that left shoulder. Typically, it's on the side that's most affected by Parkinson's. Here's good examples here. So as you see, he's restless, especially when he's thinking and talking to Dr. Sanjay Gupta here, that he's generalized, he's got trunk dyskinesias and wiggles, and he kind of does, extra movements to kind of mask them a bit. But as you see, this left shoulder really turning and popping is kind of a classical feature for dyskinesias. And we'll touch on that again in a minute. Postural instability is a very separate issue in Parkinson's. And it's defined by a specific balance difficulty that tends to live in the brainstem of patients. And it's that kind of sense where if you were to fall out of bed or tip your chair, that you react and trigger a reflex to catch yourself without having to think about it. And that's kind of that fall out of the tree righting reflex or postural reflex. And that can get lost in Parkinson's, and that lives kind of outside of this normal dopamine circuit. And that's an important piece, is that's not one that is easily rectified by just giving more Sinemet or more dopamines. That's an important one. We'll talk about that. Shuffling, as you know, is kind of an extension of bradykinesia. Freezing, some of you may or may not know about, but it is a sense that during certain triggered activities, your feet can feel somewhat glued to the floor. So sometimes it can be subtle and the foot can kind of bob, or sometimes it's downright stuck. And the more that you think about and try and push forward, the more stuck you get. Freezing is a symptom that sometimes is discussed by Parkinson's patients. And that is a tricky one we'll touch on in a minute. I think this is the last piece of this puzzle that I'm going to just briefly cover today is Festin Nation. So it's a forward shifting of the center of gravity, and some patients go from walking, they kind of speed up, and they'll have difficulty slowing down and may need their arms to catch themselves. And it can sometimes be a mechanism of falls. Many Parkinson's patients who lose that righting reflex may fall backwards, and folks who have more festination may have difficulty slowing down, and they may tip forwards. So this is the big, this is just the big slide, just for the general 10,000 foot view, is the movement disorder Parkinson's disease rating scale. So this is the international Parkinson's disease rating scale. And these are the 12 main things that we're examining, kind of the objective measures that we rate and score that we're examining while you're in the office, just for your own sake. So when you have these things going on, or especially subtle symptoms, and you're early in the course, this is always a question that we get, is it time to start medication? Is it time to start symptomatic medication? And the answer is individualized. The answer may not be yes. So the idea comes from the fact that, these are studies that have been done over and over, but there was another great study that was done in 2019, showing that Sinemet and other medications like it are, in fact, symptomatic medicines only. So these are two groups we don't need to understand in great detail, but these are two groups that either started Sinemet right at the time that they were able to be diagnosed and had a decent burden of Parkinson's disease. They either started levodopa or they didn't start levodopa. And the patients that didn't start levodopa stayed about the same as far as their grading of Parkinson scales for the first 40 weeks. And the patients that did start levodopa got better in their Parkinson scales. And I'm not, I don't think that this dosing was, this was small dosing and it was relatively the same. Everyone needs somewhat different dosing, but this was just a basic principle. And this was also quality of life scales that, the quality of life scales for the patients that were taking placebo, didn't know they weren't taking medicine, did in fact get worse. And in comparison to the patients who did take carbidopa levodopa, their quality of life scales got better over this 40 weeks. But then they gave patients medication, and the patients who were off of the medication for that 40 weeks really kind of came back into the fold and caught back up with their peers who started earlier. Now that's at 40 weeks, so that's 40 weeks of withholding medication and then restarting, and their quality of life metrics also improved after 40 weeks, and they fell in line with the original group. So, what that tells us in isolation is that, this really does prove what we've always said, is that this is a symptomatic treatment. All of our medications that we have right now treat symptoms, but they don't treat the overall disease course. There's one caveat to this that I don't show here, but there are certainly other examples, is that the folks, the folks who start some degree of medication and are thus able to do something like exercise and increase their range of motion in the affected limbs, those patients will always stay ahead of their peers who didn't start medication, at least in the studies that we see. So this is a short course. This is 40 weeks of withheld medicine, so less than a year. And these patients are not so significantly disabled that they weren't doing things like exercise and keeping full range of motion, ideally. So I would just have a big caveat to say, there are many studies that show that if you do start even low dose medication, early medication to help with some of the degree of movement, if you start somebody on the path of exercise and increased range of motion movements, they will always stay ahead of their peers who waited to start later. So this is not always, this is yet again in Parkinson's, this is a personalized decision. We have a lot more to cover, so I'm going to keep going fast. Medical solutions for this problem. So the synthesis of carbidopa, levodopa, and specifically dopa and then levodopa, and then adding the peripheral or bloodstream nausea blocking, or at least compound that would not let levodopa be converted into dopamine outside of the brain. When these things were added into the 70s and 73 was when Sinemet was officially FDA approved. These are the things that won the Nobel Prize, specifically in 71 with levodopa, but the addition of carbidopa was also a very big deal, making levodopa much more potent and tolerable. So big deal there. So when we add back dopamine, what are we expecting to improve? So without much in the way of exception, unless there's other orthopedic issues or something else going, that special kind of slowness, fine motor dexterity, large motor dexterity, fluidity, getting up and down from chairs, rigidity, speed of walking, that we expect to improve with dopamine at a sufficient dose. That being said, everybody might need a little bit different dosing, but at a sufficient dose. Tremor is tricky. Tremor, sometimes the dopamine circuit is the primary driver of tremor. About 50% of the time, people with taking Sinemet will get tremor improvement, but that means about 50% of the time you won't, and that there's extra things going on for tremor. So tremor, we put a pin in and say, watch out for tremors that don't respond to initial Sinemet. We might need other tricks up our sleeve. It doesn't mean you don't have Parkinson's. Dystonia and freezing, that dystonia thing that we were talking about and the freezing of gait that we talked about, those can also be dopamine responsive. And that's why it's important to keep track of when you're having those symptoms in relation to your medication dosing, because it could be that we just need to tighten up your dopamine dosing and move things around so that we can capture these symptoms during daytime for you. But if, so keep track of that kind of thing for sure. And dopamine also can improve speech, swallowing, even, to a degree, sialorrhea or drooling, just with increasing spontaneous swallowing and those kind of things, increasing movements. So dopamine can do quite a few things. There's also non-motor things that dopamine can do that we didn't really always recognize, but some people, as their dopamine is wearing off, especially during daytime or waking up in the morning, they can feel sluggish or have anxiety in relation to their dopamine wearing off. It's not everybody, but some people do. And being able to capture when you're having those symptoms, especially if it's intermittent and somewhat predictable, in relation to your dopamine dosing will make us both much smarter when it comes time for your appointments. So keep track of those things. But those are dopamine responsive symptoms. Then there are these non-dopa responsive symptoms, these symptoms that, maybe just throwing dopamine at it isn't going to be the whole answer. We talked about tremor already, and we'll touch on it again about additional strategies in tremor, but upwards of 50% of patients will not have significant improvement in tremor. Some will have zero, and that's important. Postural instability is that deeper brainstem reflex, that fall out of the tree reflex that we were talking about, and that is a deeper reflex relating to falls that oftentimes just increasing dopamine has nothing to do with. It's not, it doesn't, live in that normal circuit. Then freezing and festinating, so those special kind of walking problems that happen in Parkinson's patients and in other patients who have things that look like Parkinson's, those also aren't necessarily, those don't live entirely in the dopamine circuit. So there are patients who can be taking lots of dopamine and still have lots of freezing of gait. They might not have dopamine responsive freezing. And so again, keep track of when you're having those symptoms in relation to your dosing, and are we just missing an off period? I'll show you that kind of thing again. These are the types of things that we do for these issues. So for the postural instability and the freezing and special walking problems, doing physical therapy with LSVT trained physical therapists, boxing, other balance training exercises, and then specialized U-step walkers are made just for Parkinson's patients, especially who have these problems. This festination and freezing is when this U-step walker really shines in how it's designed for Parkinson's patients. And then we have dopamine-related motor complications. So now, kind of back to what we were talking about, is we have some of these on dyskinesias. So when the medication is at its peak, you might have different symptoms than when the medication is at a medium level or at a low level. And so watch out for the wiggling movements to be potentially at the peak of medication use. And rarely, some posturing and wiggling can be kind of more static and less wiggly, but more drawing at the peak of a Sinemet dose. That's somewhat more rare, but that's why we need your help to tell us when you're having what symptom in relation to when you took medicine, because the treatment of these things would be the opposite if we can march that out together. And then this is more for our fellows and other people that we're training, but biphasic dyskinesias we kind of talked about. And then more common is wearing off. So dopamine-related motor complications we'll talk about is that, that certain medications and these things can reach their peak and then wear off, and sometimes can be unpredictable into when they start, getting uptake into the brain and get benefit, and when they're going to wear off. And I'll show you that in a minute here. So this is somewhat of a classical slide. It's not perfect, but it's supposed to kind of simulate a single dose of carbidopa levodopa or other medicines, at least early in the course of disease. So you would take a dose of medication. Here, the dark gray we would say is the efficacy threshold, and the bright green, we'd say green is good, you feel good during that time. And the blue at the top is when the medication is at a high point. This is the concentration of a medication. When the medication is high, you might end up having some degree of side effects. So therefore, early in the disease, I have some other figures like this too. Earlier in the disease, you take a dose of Sinemet, and there's a large amount of time that you feel good all throughout here without side effects, and that the medication carries very well, and the therapeutic window is big. As time increases with disease, some people, not everyone, everyone's so different, not everyone, but some people will have this window start to shrink such that they'll need more medication, not because the medication's lost its effect, it's because the disease progresses, and we've kind of proven that over time. So as the disease progresses, you might require, this window might increase a little bit, not too much, but some. But then the bigger problem becomes that this window starts to shrink from the top, as if you end up getting an issue like dyskinesia, for example, is one issue. Then you might have a smaller window of time that you're able to feel as good. And as disease really advances many years, this window might become tighter of time in here. So, and you might have a peak dose other side effect that we would talk about essentially there too. So separately, you can also have kind of a steeper slope of that wear off too. This is all showing that the medication was given and then wore off at the same rate early as it does late. Whereas sometimes as disease wears on and your metabolism can pick up, or this requirement is more, you start to have a tighter window in here where you actually feel on. Maybe some people not so much. Some people yes. Here's a different example. Here's a different view. Of kind of early in the course, you're taking Sinemet 3 times a day, maybe just a single tablet, just like we'd always said, and you keep your levodopa curve nice and big, and this is all time that you feel good. But then you get into maybe later in disease, several years in, and it might be that you take a dose of medication and it kicks in and then it wears off, and that this window is getting tighter. And it's not staying in your system as long. It's getting cleared faster. And so this would be kind of predictable wearing off, that I take it here, and the medicine wears off every 3 hours. And I have to keep taking medicine. I have to keep taking medicine if it's just Sinemet, for example, or something related. You keep doing that every 3 hours and it wears off. Advanced disease, eventually, you can have other issues that are at play, like difficulty clearing it from your stomach or difficulty absorbing it from your intestines. And then you could have failed doses mixed in here, and your on time can get tighter and tighter. So this is all, this is things that we are thinking about many years into the course to try and help you if you come in with problems. Now, yet again, many people won't develop this kind of issue. They'll stay more like this. Where we know we just kind of need predictable dosing, and we just have to listen to how you're going to teach us. We need to give you the medicine to keep you feeling good. So this is an example of a diary that I give to my patients before we're considering something like deep brain stimulation, or if we're having trouble charting your symptoms and how to get on a schedule best. So this is just one that I made up. It's color coded as to when you took your medications and when you feel off. So if there's particular times where you're not feeling good, chart them down and you can grade them as to what and why you had those symptoms then. And then this is that possibly peak dose dyskinesia, or when you're having these wiggling problems and when you feel good, because if you're charting when you feel pretty good, we need to know that too. So keep bringing something like this, or at least having just a very general concept of that kind of thing in mind when you come to a visit, especially if you're able to average it over the course of 5 days or a week, that you're finding similar trends. Man, we're both going to be smarter when it comes to changing medicines if that's the case. So I'll jump into levodopa and dopamine handling in the brain, or at least the basics. So this is what we were talking about before, is that the levodopa in this case, that being Sinemet, we'll talk about it. If it gets once it gets past the stomach at a variable rate, gets absorbed in the intestines, comes into the bloodstream, there's a couple different points of interest, and these are all where pharmacologic targets are. So there's a couple different points here. This is where the carbidopa comes into play, is that we don't want the levodopa converting into dopamine in the bloodstream. We want to save it for the brain and not make you nauseous. And so that's where carbidopa came into play and why it's always linked with levodopa. And carbidopa can't get into the blood-brain barrier, which is great because it means that the levodopa can come in and then get converted to dopamine. So then dopamine, levodopa gets taken up in the bloodstream as if it's your own levodopa and gets converted by your own cells to dopamine as if it's kind of your own. So as much on that natural pathway as we can get. This entacapone is another way where this levodopa, sometimes instead of going to the dopamine that we want, gets broken down. And so entacapone is a way to intervene both in the bloodstream and in the brain to make it so that levodopa doesn't really get broken down so much. And I'll circle back to this figure in a minute. The other medication classes like our MAOB inhibitors, and we'll talk about them, also limit the amount of dopamine getting broken down, especially closer to the site of action. So those are the main mechanisms of these medications, and that we'll walk through, at least in relation to dopamine. Then there's a couple other spots as well that have intervention. There's amantadine classes, has a mixed mechanism we'll talk about. And then also the dopamine agonists, represented here by an old medication, bromocriptine, that we don't use, but represented here, where the bromocriptine or if it's Mirapex or Pramipexole or Ropinirole, Requip, or Nupro, they act synthetically directly on the dopamine receptors themselves. And I'll show you that in a minute. But so they are outside of this pathway and outside of this normal kind of more naturalized pathway. They act directly on the receptors themselves. So here's kind of the first page that we have, because there's so many medications. We're not going to walk through every single one of them, but now if we understand the strategy and why we're using what meds, I think we'll be smarter. So medications currently available to treat Parkinson's disease. This is updated, I believe. There has just been a litany of new medications. They're coming and coming. So the classical levodopa formulations include carbidopa-levodopa, the original medication, 1973, and then carbidopa-levodopa, Cinemet company tried to make a controlled release version. It's not great, but they tried to make a controlled release version that they put in a kind of crummy capsule that would just get dissolved slowly in your stomach. The problem is it's just too variable, even in the same patient, let alone other patients, to use during daytime. We use it mostly at bedtime as a slow release of Cinemet, but it's not so much great for daytime use unless you're a very special patient. Then 2015, I think you might have seen on the other, in 2015, both Rytary and Duopa were approved, and those are also still our good old faithful carbidopa-levodopa formulations, but they're in new ways of giving it. So Rytary is a capsule and a pill, and there's lots of different small beads that release at different times. So it gives you that smoother curve for a single capsule or single dosing that we really like, potentially, if it's right for you. But they did kind of what Cinemet controlled release knew that it had to do, but just engineered it in a much smarter way. So that was 2015 that was released. Levodopa intestinal gel, or Duopa, is carbidopa-levodopa infused directly into the intestine, so bypassing the stomach, that can slow things down unpredictably and go right into the gel to stick right where it's absorbed best. So sometimes people with variable absorption and those things can have kind of a laser focus of their levodopa with a gel that's put right on the intestine. And then this Inbrija is a newer medication that's inhaled levodopa, so it's aerosolized, and this is kind of an as-needed type medication for mild off times. But so these are all the old-fashioned levodopa with new twists. These next medications these classes are the ones that help the levodopa hang around longer. So make it so that they don't so much boost the effect, the peak effect of the levodopa, but they help keep it around for longer, which may be the appropriate goal for you. In which case, adding these types of medications, with entacapone or Stalevo, where entacapone is built in to the carbidopa-levodopa, or selegiline or rasagiline, those being kind of the most common medications in these classes, will help keep your dopamine around longer in your brain. like that figure I showed was here, like this one. So they'll help keep the levodopa around acting longer by either not letting the dopamine get broken down or not saving this levodopa so it pushes down this pathway farther. Opicapone and safinamide are the newest kids on the block in each of these classes. Opicapone being even newer, just late last year. Then very separately, we have these dopamine agonists, and we're talking about this, that these are the medications that you know, are completely off of that classical levodopa dopamine radar, and that they go in the bloodstream, cross into the brain barrier, your blood-brain barrier directly to the brain, and act right on those dopamine receptors deep in the brain that we're missing that dopamine gasoline. These kind of hit and mimic the signals that get sent, you know, because they kind of mimic the dopamine itself. So they act directly on the receptors, and they're kind of off of this dopamine cycle that we've been talking about. So then we have the anticholinergic medications. So medications like trihexyphenidyl, benztropine to a degree. And then we have these amantadine classes. So if patients have refractory tremor, they might have a tremor that's more responsive to these anticholinergics than they do the classical dopamine. They might need help on a circuit that's a little bit different than the regular dopamine circuit. And then in that same vein, amantadine, which has a mixed mechanism, also can sometimes hit that circuit and be a little better for tremor than just classical dopamine, if these medicines are otherwise right for you, we'll talk about. Dyskinesia, so that peak dose dyskinesia of wiggling can be treated. The only medication that has an indication, the only medication class that has an indication to treat, to use a medicine to stop that peak dose medicine side effect, is the amantadine class of medicines. And more recently, Gocovri and Osmolex, Gocovri mainly right now, are the newer extended release versions of that amantadine class of medicines, amantadine being an older medicine even than Sinemet. Finally, we have another new kid on the block that we're all still getting to know, called istradepylene, or Nurians is the brand name, and it's an adenosine A2A receptor antagonist. It works in the indirect pathway, and it works kind of differently and you know, in some degrees more mildly, but we see if that kind of thing is right for you. You know, but we're all still getting to know that medicine, because it, as you can see, you know, these have been the major classes of medicines, you know, since, you know, some of these back into the 70s, and some of these, you know, previous versions of these of MAOs were used long ago. These MAO B inhibitors, so these are all very specific for Parkinson's, not the old antidepressant medicines that have a whole lot of side effects. These are newer, but we haven't had a new class of medicines in a long time, and this is a new class with a novel mechanism that we're kind of getting to know. So now we talked about all these medications, and I just want to make sure that you know, we'll talk about the ins and outs of them in a minute, but I just wanted to make sure that people understood to a degree, you know, where does something like DBS fit in to this equation? And the answer is, you know, in moderate disease, you might start, as we talked about, having those kind of predictable wearing off, and we need to tighten up your medication dosing during the day to give you a smoother experience and kind of maximize your functioning. DBS is when we really start getting into issues like just refractory to medication changes. We're getting stuck with these dyskinesias or motor fluctuations. You're having impermissible side effects, and we can't keep you functioning when you're otherwise healthy. Here is also, on this line over here, refractory tremor. DBS is excellent at treating tremor, even tremor that's not well treated by classical Sinemet, and you know, may or may not be by other medications if you tolerate it. So this is the time to intervene with DBS, is earlier in the course, when you're getting hints and signs that medications are not going to do the trick. And you know, especially if you're still trying to work and do these things. That's a great time to intervene with DBS. The time not to intervene is when DBS also doesn't help so much of things like postural instability, freezing, if you're having significant issues with falls, dementia, that's not the time to intervene with DBS. Those aren't the patients that do well with a brain surgery for the most part. So that's most of what we're talking about. We'll be able to circle back. I think we'll have a little time for Q&A. I just want to go back and say that motor symptoms are not the whole story. So with progression of Parkinson's disease and progression of the disorder, starting down low and starting to affect dopamine replacement and those kind of things, and then affecting more of those circuits we were talking about, more issues we have to take into account, maybe or may not be things like hallucinations or delusions, and we need to take into account memory and cognitive impairments, dropping of blood pressures. Those all play very specifically into whether or not we can be giving you as much dopamine as your dopamine circuit would need, but you may end up with more side effects from these. So here's where we talk about this. So the basics of side effects of these medications, for the most part, several of these medications can worsen underlying orthostatic hypotension already caused by Parkinson's, or potential for hallucinations, typically already in line with Parkinson's disease already, or can be novel. So the idea being that dropping blood pressures when you're standing up, so keeping track of those standing up pressures, can be worsened by marching up dopamine indiscriminately without us asking you about that kind of thing, especially those dopamine agonists. Those are excellent at bottoming people's standing blood pressures out. So watch out for that. Hallucinations. So dopamine agonists, anticholinergics, some of those COMTs especially can be really good at giving people hallucinations. So these anticholinergics, those medications like Artane, especially benztropine, are really good at giving people hallucinations and memory and thinking impairments. So I do not like using them unless in a very young patient. So that's a general scheme as to why you may not have had those medications come across your pill boxes, because we don't like using them in those kind of situations. So medications can also cause dopamine-induced dyskinesia, as we talked about. So increasing medications can maybe worsen dyskinesias in some cases, except for the amantadine class, like we talked about. That's the class that treats dyskinesias and wiggling. Lower extremity swelling, impulse control disorders, sleep attacks. These are all dopamine agonists, bread and butter. So all these medications, these Mirapex, Requip, Nupro. We didn't talk much about the rescue apokins and apomorphines. Those are kind of the rescue medications, but they are really good at all of these type of problems, orthostatic hypertension, hallucinations. So that's why oftentimes very young patients are the ones who get those dopamine agonists, and not patients as they age. And then we'll touch on just a little bit more of these non-motor symptoms very quickly. I'm not going to go through all of this, but non-motor symptoms in Parkinson's, we've got tricks up our sleeve that are pretty well tolerated for the most part for almost all of these symptoms. So, we should be talking about it and setting goals and making sure that you're not suffering without letting us know. So things like autonomic symptoms, neurogenic orthostatic hypotension, we talked about. There's several medications that help keep your blood pressure up. Neurogenic bladder can be tricky, especially in our guys if they have, and in our female patients actually. But there is a component from Parkinson's related to that. There also could be other components that aren't related. But there are medications to treat urinary frequency urgency and constipation. Depression, anxiety, apathy. I thought I had a slide here, but remembering that dopamine is not the only neurotransmitter that's affected. Sometimes serotonin is also affected in Parkinson's, and that makes replacing it, or at least stopping up the sink so that your own serotonin hangs around more, much more effective than in the average person. So let us know, because antidepressants work better in our Parkinson's patients than most people. Punching, kicking, REM behavior disorder, insomnia, sleep fractionation. We've got tricks up our sleeve for that kind of thing. Fatigue is a tough one that needs to be individualized. Make sure that you're not having orthostatic hypertension, because that makes people really fatigued. And then cognitive symptoms, again, removing all these offending medications that we talked about and ones that other doctors would prescribe you. And then, donepezil, ribostigmine, improving the acetylcholine tone can help patients with memory, thinking, hallucinations as well. And then there's medications for hallucinations and delusions that I'm sure that you've seen commercials for. I wish you didn't, but they're out there, and those are out there as well. So before we close, I know I went real fast, and we'll be able to circle back to slides, but take-home points, just so that you know what we're kind of focused on and talking about. Therapy, medications are centered around replacing that missing dopamine. That's what all of these medications are geared towards doing. Carbidopa, levodopa is the common backbone of the treatment, and many of these medications are used around carbidopa, levodopa. So they're used to help it or to boost it up. There are many Parkinson's disease courses that are all different, and so therefore they need different medication paths for each patient. As you saw, we would kind of tailor which meds we use and why, depending on what issues that a patient is and isn't having. To date, medications are for treating Parkinson's symptoms to maximize your quality of life currently. Exercise is for treating Parkinson's disease and progression. So we want to be giving you medications to improve your quality of life, and so that you can exercise. So it's all the above. It's all of that. So with that, I think that's my last slide. I can close, and then we can kind of circle back. I know that was a lot of information, and I'll just scroll back and hang out on this slide for a minute.
So at this time, I'd like to invite anyone that has any questions to feel free to take yourself off mute and ask them directly, or if you're uncomfortable with that, you're certainly welcome to use the chat feature. You can chat to me as the host, or you can chat directly to Dr. McLeod and he can answer you that way.
Let's see if I can see the chat while I'm sharing. Yeah.
And I'm also going to monitor Facebook.
Can you hear me, Tamara? I have a question.
Yes, please go ahead.
Okay, this is Connie.
Hello.
If you have an event or something like a wedding that you're going to, is it okay to take a higher dose or an extra dose of Sinemet?
Sure, if you know what it does to you and for you, and you know what the goal is, sure. It depends, yeah,
I don't want to put you on the spot, but I know if you anticipate that you're going to be wearing off, halfway through an event or something.
Yeah, no, I think that's a great idea. If you know what your wearing off is, if you have an unexpected wearing off, or if you want to stay out ahead of it, what 2 tabs does for you and what your peak dose side effect is. I just wouldn't want you to have a surprising side effect because it's the first time you've taken that extra dose. But if you're prone to unexpected wearing off, absolutely, you can keep a pill in your pocket, take it. There's also that's exactly where a lot of these companies would be upset if I didn't mention that all of these, we have all these new as needed medications. So this inhaled levodopa is used to a degree. Apokyn is is kind of like a bazooka, but in patients that really fluctuate. They can take a shot in their leg with this Apokyn. This sublingual apomorphine, we're all getting to know and make sure that you tolerate it in your mouth and we get the dosing right. But this is one of the newest kids on the block. Is the sublingual apomorphine, and keeping that in your pocket as you're wearing off with a quick, that has a quick infusion and time to peak rate would be the even better idea. But that's where people who fluctuate and have unexpected offs and they don't want it at a specific time, those as needed medications can be a great solution. We're so happy to have them in our repertoire.
Wonderful. Okay.
Mhm.
Dr. McLeod, I had a question come in that I'd like to ask you
Of course.
on behalf of some of our audience. The question is with regards to the side effect of gambling and how to maybe address that.
Excellent question. Did it happen long, yeah. There can certainly be a very mild-mannered, non-risk-taking, non-gambling human being who develops Parkinson's disease, and just as a matter of course of Parkinson's before medicines, has some degree of disinhibition and tendencies towards gambling or hypersexuality or other features. Then you can enter the medication augmented world, especially in that Parkinson's patient. Dopamine agonists are the classical medication that you really have to screen for and take extraordinary care to see that patients don't have impulse control disorders like gambling come on as a consequence of those medicines. Sometimes the dose doesn't matter. Sometimes you don't need a dose change. Sometimes how long you've been on the medication doesn't matter. I don't like any of that. So always are asking those things. And it's one of the reasons that I very rarely use that class of medicines, because even though it is a rare side effect, it can be a big problem. And even in non-Parkinson's patients, so just restless leg syndrome patients, we see that using dopamine agonists, those same classes that are up there, can induce impulse control disorders in those folks too. So it's not just Parkinson's patients. That is a big and serious problem.
So is it your recommendation then to really kind of track this, make sure it is associated with the medication, and then bring that into our doctor and
yeah,
discuss
absolutely.
okay.
Absolutely. And I mean, and if the doctor is prescribing you certain medications, theoretically high doses of all these medicines can induce something like that. But if you have a previous issue with gambling, that could factor into the decision as to which medication we choose. If you have a new issue with gambling, let your physician know, because we might need to change up your medications immediately. I mean, I would want to know fast before we get out ahead of it. The only thing I'll say to the caregivers in the room is that there have been these strange cases where patients kind of hide it, either for sake of, I'm not sure, embarrassment or the reward pathway in their brain as kind of a addicted form of that kind of thing. They can kind of hide it, and it's why I tend to stay away from that class of medicines unless I really get stuck, because of that rare side effect. So I would take it very seriously and let us know immediately.
Okay, thank you so much.
Sure, of course.
Dr. McLeod, this is Kathleen.
Hi.
Continuing with Connie's question, is the inhaler a good idea for the
rescue?
Risk the what do you call it, the off moments when you're going somewhere?
It could be. I haven't used it very much, but it could be both that and the sublingual. Could be something to carry with you when you have a surprising off period getting stuck, to take out and has a much faster onset than a typical Sinemet would. It also kind of crashes more quickly than a Sinemet would. But by then, you could ideally be to your next dose, and your next dose would be taking over. But if it's right for you, it could be great. It could be something that's nice to have for those unexpected times or those important events that you really want to make sure that you don't miss.
Can you tell me how long it lasts? For example, one puff or one sublingual?
I would need to relate to their pharmacology curves and those things again. I think that the onset is somewhere around 10 to 15 minutes, and that they did studies of it lasting around 60 minutes or 90 minutes. And so same with the sublingual apomorphine, they were pretty close. They didn't, they weren't huge movers in the scale, in comparison to Sinemet or in comparison to medications like that. They weren't, huge movers, but the sublingual apomorphine actually and some of those had very modest improvement though of that unified Parkinson's rating scale. So it can really help symptoms. But yeah, it tends to be something around 15 minutes of onset, and they studied it around 60 minutes and 90 minutes to see how long it lasts.
Thank you. Thank you very
Sure,
much.
Of course, of course.
Are there non-Parkinson specific medications for things like rigidity and curling toe spasms, like maybe a
So those are pretty different. Rigidity, I mean, not easily for rigidity. Dopamine is usually the answer, and you know there are muscle relaxants, and there's other medication classes that do different type things like the baclofens and things like that. But that's not for pure rigidity. You know, dopamine is the right answer. For dystonia, which we think of as being a little different than rigidity, dystonia is the act of curling of your limbs, and in this case potentially toes, ankle, those kind of things. Amantadine can be more helpful for dystonias in Parkinson's, but Botox is an excellent choice, which isn't on here. Botox is off the radar of these medications I didn't mention, but is excellent for dystonias, especially off dystonias that don't respond as well to dopamine anymore, and those kind of things. The classic would be a turned in foot when you're wearing off, or a morning off in that foot that kind of has trouble with medications and those kind of things. Sometimes Botox is the right answer for that.
Yeah, I've had that done several times at Penn, and it's wonderful. It's just that it's very expensive. So.
I would expect it to not be expensive. I don't like hearing that. It is the kind of do not pass go, do not collect $200 dystonia treatment. So I hope not. I know Botox now has a savings plan. We have multiple for Medicare carriers and not. But gosh, it's been a while since I've run into patients telling me that it turns out to be expensive for them. You don't look at the bill as to what your insurance is paying and those kind of things. And I hope that the copay is not expensive, but I know that Botox and then a couple other companies have copay assistance programs and savings programs that help throughout the year. But it is only 4 injections a year.
Mm-hmm.
I mean, max.
Yeah, I'll look for that.
Sometimes you need less, but Botox.com and BotoxSavings.com are a nice way to save on those copays.
Good. Thank you.
Of course.
I have a question about Parkinson's disease and dementia.
Mm-hmm.
I've always been kind of fascinated by that because I don't understand what part of the brain is affected, what kind of dementia it is, and can you get it in the early stages?
Very interesting questions, all of which. Let me see if I can find let me see. Here. Yeah, this will work.
Oh, yeah.
So yes to all those things. The first thing I'll say is if you're getting, making sure that you have the right diagnosis is important because Parkinson's disease should progress in somewhat of a stepwise way, and some people get more cognitive impairment than others, a little earlier than others, but making sure that you have, the right diagnosis and that you're not missing either secondary diagnoses or something like Lewy body or something completely different or concomitant Alzheimer's. But the idea is kind of like we were talking about, is that earlier in the course especially, we've always known about these. You probably can't see these very well. Don't worry about it if you can't. This dark black dot in here in the middle of the brain, of the midbrain here, is the dopamine marker that's projecting into the middle of the brain that helps movement. There's also a dopamine measure here, similar that's going to other mesocortical limbic pathways that helps regulate emotion and foggy brain. So that's where sometimes just dopamine can pick up that foggy brain that people early on felt like was missing. The other thing early on is that the acetylcholine system that's stored in the nucleus basalis of Maynard and elsewhere, also in the brainstem, but mainly here, can be hit in Parkinson's in a different way than it is in Alzheimer's. So again, it's kind of hit by the stores itself, which means that if we replace the store, if we're replacing the cupboard, but the brain tissue is still functioning, things like acetylcholinesterase inhibitors work better for our patients than they do for Alzheimer's classical dementia patients. So those are important things to keep track of, and to make sure that our medications aren't making patients have problems, or other physicians' bladder medications aren't affecting our Parkinson's patients, because those will also all give cognitive impairment. So that's the first line of defense, and why dementia medicines work better for us than they do for many Alzheimer's folks. That's number one, is because the not having actual brain tissue destruction. Secondly, as this progression shows, and many autopsies show, there are multiple areas, if the dark shaded areas being areas that are then affected by Parkinson's, that as Parkinson's progresses, you can actually have cortical pickup of alpha-synuclein related neurons and neuron cell death in certain areas of the brain. The areas of the brain that tend to be affected are more frontal areas, so different than Alzheimer's folks. So we'll have different problems as it progresses, and that'll be the more dysexecutive symptoms, so more of difficulty multitasking and listening to multiple conversations because of the area of brain that's affected, and kind of set shifting and doing executive type work. And then also some of the visual spatial areas can get affected earlier than an Alzheimer's patient. But the pure amnesia, and then some of the other issues that progression of Alzheimer's patients get, a Parkinson's patient wouldn't be expected to get, because the area that would be affected would be different. So I guess that's a lot of way to say the take home point is, first, make sure that we're not messing things up with a medication or something else. And then second, use what works better for our folks than most, because you can just have store problems. And then third, some people, as Parkinson's progress, have an irreversible damage of some specific areas in the brain that can give you dementia.
I am a clinical social worker, and as such, I'm interested in the psychobiological aspects of the patient.
Excellent.
And so I'm wondering, based on what you just said, is there any way to predict the onset of dementia as the disease progresses?
There have been lots of interesting research metrics to that, and trying to figure that kind of thing out. I'm not sure in what kind of setting. What do you think? What are you thinking? You mean just clinically, like at home?
Yes, well, clinical as in the diagnosis itself. As the diagnosis is revealed to the clinician, how well can you predict the onset of dementia?
Oh, Dr. John Morgan would love this question, and also dread it, because he can have an entire lecture on, so he's our Center for Aging expert here, but he's also the head of the Movement Disorder Division. And he could have a whole lecture about how to clinically diagnose the progression between mild cognitive impairment and dementia, because there's not any good measures for that already. You know that. But then, prediction in a given patient population, I'm not so sure that I have a good answer for that, as to predict who will get or when they cross that threshold. I mean, I always rely on caregivers and family.
Maybe we can get Dr. Morgan to come over and answer that.
Let's do it. Let's do it. Oh, well, yeah, no, he's, I'm sure, running still deep into clinic here, but yeah, no, he, I'm sure we'll do a whole separate topic on cognitive impairment specific to Parkinson's. He's an excellent person for that.
Thank you.
Dr. McLeod, I'm going to wrap things up for you.
Sure. I
I know we committed to keep you on for an hour. We've gone a little bit over. I don't know if you have any last thoughts before we jump off.
I don't. I mean, I'll just circle back to this last page just for a minute and just make sure that no one has any questions. Lost it. Nope, these were just the take-home points.
Okay.
That was it. We're here. We're here for you. So let us know what's going on, and try and pay attention. If you're having trouble, pay attention to when you're taking your medicine. Make a little diary. I think I showed you an example, and what problems you're having when in relation to the medicine, because if we find patterns, we'll both be smarter.
I love that. We actually are working on some planner notebooks to give to some of the folks at the gym to keep track of that stuff. So
I love it. I've been looking all over. I know I kind of made this one myself, but I've been looking all over, and it's tricky. It's tricky to find good ones.
I will send you ours for your seal of approval when we get it ready to go to print, if you don't mind.
Of course. Bring it on.
Real quickly, for everyone else out there, thank you so much for joining us. I know that this is a unique and different way to connect and listen to some good information, but I appreciate everyone giving it their best shot and working with us and doing this. Also, real quick, before we jump off, 2 quick announcements. This is our 30th year celebration. So happy anniversary to the support group. It's phenomenal that it's been going strong for 30 years, and all of you guys are a part of that. So again, just wanted to make that real quick announcement. And then secondly, for everyone that's on here, it looks like we'll be doing these Zoom meetings for at least the foreseeable future. So starting with February, we're going to move these to a 6 p.m. evening time instead of 3 p.m. So it'll be the 4th Tuesday at 6 p.m. going forward. And next month, we're going to have a speaker from Parkinson Place to tell us a little bit about all the online resources that they have available for people during this strange time. So stay tuned, join us for that one. And again, thank you so much, Dr. McLeod. We really appreciate it.
Of course. See you next
All
time.
right. Goodbye, everyone.